Hemolytic anemias. Dr. Suhail Bas Ahmed. Hemolytic anemias, HAs. HAs are defined as those anemias which result from an increase in the rate of red cell destruction. Any condition which leads to a reduction in the mean lifespan of the red cell is a hemolytic disorder. Because of erythropoietic hyperplasia and anatomical extension of bone marrow, red cell destruction may be increased several-fold before the patients become anemic, compensated hemolytic anemia. The normal adult marrow, after full expansion, is able to produce red cells at 6 to 8 times the normal rate. Therefore HA may not be seen until the red cell lifespan is less than 30 days. Classification of HA. The HA can be classified in several different ways. 1. Site of hemolysis. Extravascular hemolytic disorders, macrophages of the REs. Intravascular hemolytic disorders within the circulatory system. In many of the cases there is a combination of both extra and intravascular hemolysis. Extravascular hemolysis. Red cell destruction usually occurs in the cell of the REs. Intravascular hemolysis. Destruction of red cells occur inside the blood vessels. Classification of HA2 site of defect. Intrinsic defect, intracorpuscular, structural or functional defect within the red cell. Extrinsic defect, extracorpuscular, an abnormality in the red cell environment. Classification of HA3 inherited or acquired. Inherited HA are usually caused by intrinsic defect, while acquired HA are caused by an extrinsic defect. However, there are some exceptions: paroxysmal nocturnal hemoglobinuria, PNH, which is an acquired intrinsic defect, and severe hereditary 6-PDNs deficiency, which requires the presence of an extrinsic trigger such as the anti-malarial drug for the intrinsic defect to manifest. Inherited and acquired HA. Hereditary HA. Membrane defect C.G. Hereditary spherocytosis. Metabolic defect E.G. 6-PD deficiency. Hemoglobin defect C.G. Sickle cell disease. Acquired HA. Immune. Autoimmune EGA. Alloimmune.G. HDN, HTR. Red cell fragmentation syndromes. March hemoglobinemia. Infections. Chemical and physical agents. PNH. Approach to the diagnosis of hemolytic anemias. Patient's history. Good history is essential to provide guidance for the diagnosis of hemolytic disorders. The following points should not be neglected. Family history, hereditary conditions, mode of inheritance. Ethnic origin. G6PD deficiency is most common in Mediterranean and Chinese populations. Past history. NMJ may be indicative of congenital conditions as HS or G6PD deficiency. Triggering events, history of drugs, infections, clinical features, pallor of the mucous membranes. Mild fluctuating jaundice. Splenomegaly. Dark urine. Pigment gallstones. Ulcers around the ankle. A plastic crisis may complicate viral infections. Growth retardation. Hypertrophic skeletal changes. Leg ulcers in patients with severe congenital hemolytic disorders. Leg ulcers in patients with severe congenital hemolytic disorders. E.G. Sickle cell anemia. Skeletal changes in patients with B thalassemia. Laboratory findings. The lab findings are divided into 3 groups. 1. Features of increased red cell breakdown. 2. Features of increased red cell production. 3. Damaged red cells. Laboratory findings. 1. Features of increased red cell breakdown. Raised S.bilirubin, and conjugated and bound to albumin. Increased urine urobilinogen. Increased fecal stercobilinogen. Absent S.haptoglobins, saturated with Hb and removed by the Re cells. Laboratory findings: 2 features of increased red cell production. Reticulocytosis. Bone marrow erythroid hyperplasia. Laboratory findings: 3 damaged red cells. Morphology: microspherocytes, elliptocytes, fragments, etc. Special tests: osmotic fragility, autohemolysis. Red cell survival is shortened. This is best shown by 51's labeling with study of the sites of destruction. Reticulocytosis is a feature of increased red cell production. New methylene blue is used to stain the reticulocytes. Fragmented cells and bitten cells are signs of damaged cells occurring in hemolysis. Intravascular hemolysis. Intravascular hemolysis. Free Hb will be released from damaged red cells. This free Hb will rapidly saturate plasma haptoglobins. The complex will be removed by the liver. The excess free Hb is filtered by the glomerulus, and free Hb will enter the urine. As iron is released, the renal tubules become loaded with hemosiderin. Methymalbumin and hemopexin are also found in the process of hemolysis. The process of intravascular hemolysis. Liberation of free Hb. Filtered through the kidney. Appear in urine as hemoglobinuria. Lab features of intravascular hemolysis. Hemoglobinemia and hemoglobinuria. Hemosideриnuria, iron storage protein in the spun deposit of urine. Methymalbumin, detected by Shum's test. Hemoglobinuria. Notice the dark color of urine compared to the normal color in the other container. This is a sign of intravascular hemolysis.